have all day today. I've got like 3 new things to cover, and then the rest of today is like review, practice, apply, stuff like that. So you guys tell me, like, what area do we need to focus on today?
Just start with
All of it's not an answer.
I'm just kidding.
I guess what is striking you guys is like the heart. Priority. Heart interventions, okay. For like just all the things or like rhythms? Okay.
Yeah.
Okay. Have a whole activity, okay. We'll do a whole lot of review on that, like when I get done covering the next 3 things I wanna cover. I'll get the monitor up here so I can just roll through different rhythms. So I actually have a little fun game with that. Alright, so I wanted to bring back congestive heart failure really quick and kind of do quickly review. I left one thing off that's actually up on this slide that we didn't talk about. So I wanted to kind of come back to CHF for just a little bit. How are we feeling about understanding CHF? Kind of, sort of. Okay, so if I tell you systolic dysfunction, which is HFR, EF, what does the R mean? It's reduced ejection fraction. Okay, so that means what with the heart? What's going on with the heart if we have reduced ejection fraction?
Ejection fraction is less than 50.
Yeah, it's bogged out, it can't pump well. Sorry, this is like alright, so it means the heart is overstretched, it can't get a good contraction, therefore we don't push out enough blood in order to perfuse our organs. So if you have left-sided heart failure, what kind of symptoms are you going to have? Pulmonary symptoms. Pulmonary symptoms, because if only 20% of your blood is going forward, where's the rest of it? It's going backwards and it's going to back up in your lungs. What's going to happen to the rest of your organs? Yeah, we're going to start seeing signs of lack of perfusion, so they're not going to function as well. So we can see signs of kidney failure, poor perfusion, just all in general, but we're going to see a lot of pulmonary signs. That's the number 1 patient you're going to see in the hospital, is you're going to see left-sided reduced ejection fraction heart failure patients. Number 1. The other ones you're going to see as well, but they don't cause as many problems to make the patients come into the ER and come into the hospital. They're a little bit more managed at home and don't have quite as many bad exacerbations that force them to come to the ER. So by far, like, that's the one that you, like, just as a nurse in general, need to understand, because it's the patient you're going to be taking care of the most. All right, so what kind of treatment plans does this person need to be on if they have heart failure? What are we going to do for them? Diuretics. So we're going to have them on diuretics. So let's kind of talk about home maintenance versus hospital maintenance. So when they come into the hospital and they're having an acute exacerbation, what are we going to do with them? What kind of diuretics? Loop. Those strong, powerful loop diuretics, because we want to decrease our preload or afterload with that one. Preloads. We're going to decrease our preload. If I'm giving them 80 to 100 milligrams of furosemide, which is not an uncommon order, what am I worried about? I'm worried about potassium, so I'm probably going to have to replace potassium for these folks. Okay, so taking that knowledge, let's talk about being at home. What kind of diuretic is going to be a good home diuretic for them to be on? The spironolactone, because we want that potassium-sparing diuretic for at home. So when they're at home, we're going to be doing that daily maintenance dose of that spironolactone, however you say that long word, at home to try and keep their preload under control so they don't have exacerbation. When they come in the hospital, we don't do that diuretic. Why? It takes too long to work, it's not as powerful and effective, so we don't like that diuretic when they come into the hospital because it's not gonna give me my good results. Furosemide is gonna be like, get that preload out, go on, and get all that fluid off of them. Okay, so diuretics, what else we're gonna give them when they come into the hospital?
ACE inhibitors.
Alright, so the ACE inhibitors, we can still give it to them, but ACE inhibitors, do those hit really hard, really fast? Not really. So the ACE inhibitor is going to be a little bit more of a home maintenance drug. We're still going to give it to them because they need it, but it's not going to give me my like big results like I want. As opposed to like a beta blocker. Can we give a beta blocker in a big, potent, powerful dose? We sure can, because we can give our metoprolol in an IV dose, and we can get a real big, potent result with a beta blocker with an IV. We're still going to give them their ACE, though. It's either going to be an ACE or an ARB, so we don't give those two together. Do you remember that from our medication activity? We don't do those two together. You're going to get one or the other. In style now is more of the ARB, that Entresto with the combo drug, so that's kind of the more common one. But we don't have like a big IV dose of Entresto. We can give a big IV dose of an ACE inhibitor, but all right, what we didn't talk about was cardiac glycosides. So we kind of glossed over that one. And then we didn't have a group present cardiac glycosides. So that was the kind of one big thing I wanted to go back over, because there's really just one cardiac glycoside that we give. What is it?
Digoxin.
Digoxin. That's the one that we give. So we didn't have a group present that. We don't give a ton of digoxin anymore. This is about the only time you're really going to see it, is somebody having an exacerbation of CHF, and even then sometimes they don't give it because we go with the beta blocker, kind of does the job we need it to do. However, you need to know about digoxin just in general, and then a couple things with Inclex. So digoxin, cardiac glycoside, it's positive inotrope. So do we know what positive inotrope means? It's going to give me a stronger contraction. So that's its whole purpose, is to give me a stronger contraction. So that's what it's called. So when you read those words, you'll know what those words mean. As a positive inotrope, it's going to help me give a good contraction. So its whole point is to try and get this big stretched out body heart to come together a little bit better. Because of that, it decreases your heart rate. So anytime you ever give digoxin, you're going to get a little alert in Cerner or Epic or whatever, and it's going to ask you, what is your patient's apical heart rate? And it's going to ask you to count it for a minute. And you're going to have to enter that before you can give it. So we're going to hold digoxin if your heart rate is less than 60. So we're going to hold it and talk to our healthcare provider. Digoxin doesn't quite have the same effect. Like if we have somebody on a beta blocker and their heart rate's less than 60, I'm calling that healthcare provider and they might tell me to give it, no matter what. I've had healthcare providers tell me to give a beta blocker dose and the heart rate's 45. I'm like, are you sure? They're like, yep, because not giving it's too dangerous. Like we have to give it. I can't make that call as a nurse. I have to let a healthcare provider make that call. So I'm going to call them to make the decision. Do I give it or do I not? If I'm above 60, I'm safe to give it. If I'm below 60, I'm going to call and let them decide. That's with any of these cardiac drugs. But beta blocker is very dangerous to hold. Dig, not quite so bad. So dig tends to go toxic easily. So this is your Inclex stuff. Is your digoxin toxicity. So there's some classic signs of digoxin toxicity. You may know them. There we go. Vision changes. You have a yellow or a green halo to your vision, blurry vision. So that is a classic sign of dig toxicity. It's visual changes. There's other signs too. There's nausea. There's vomiting. There's a couple of other little vague ones. But kind of like the classic NCLEX. How do you know your patient's digitoxic? Vision changes. So yellow or green halo, blurry vision, double vision, kind of any of those visual changes. We're going to worry about digitoxicity. And we have an antidote to it. I know the antidote. Digibind. So it's going to bind to the dig and get it out. So digibind. So that one at least is an easy one to remember. Digoxin, digibind. D-I-N-D. So it's going to bind to it and get it out. So that's our antidote. So that's another NCLEX thing. And we can give this IV, is most commonly what we give. So, did y'all have to break ampules in the lab? I didn't do that, did you? Break ampules? Digoxin's one of the very few things that still come in ampules that you have to break. So, we don't have a whole lot of things in ampules anymore, but Dig is so old and still is manufactured the same way as it was years ago, so it's still coming out in those ampules. It's one of the few things. I can't even remember another med that I've seen in an ampule in the last several years. Like at all. Y'all seen any meds in ampules at the hospital? Did you? Just don't see it. Like I see them in like central line kits for like lidocaine for like the docs to pull up. Anyways, side note. So those are the main things we're going to do with a patient coming in with heart failure. So the dig is going to help with a better contractility. Our beta blocker is going to help with that afterload. Keeping them on the ACE of the arm is going to help with that afterload. And then we're going to hit them with the diuretics to get rid of some of that excess preload. So we're going to hit the preload and afterload and then the actual pump of the heart. When you get to 211, we've got some even more powerful medications that help with the pump of the heart that you're going to learn then. So, you know, this is like somebody coming in and getting admitted to the floor. In an exacerbation, you'll learn more about somebody having to actually go all the way to ICU with those medications, 211. So how do we feel about heart failure? Like in that whole conversation, any questions pop up, things we weren't clear on with heart failure?
Can you say the meds one more time, like beta blockers for preload, afterload?
Is that just the one? Just think about any of these ones that affect blood pressure are always going to affect afterload, because what's afterload?
The pressure.
It's the pressure that so either ventricle, so that the ventricle has to overcome in order to pump.
The ones for preload is the diuretic.
It's diuretics, because remember preload is a volume.
The rest of them are
Or afterload.
I was kind of just gonna ask that, like a recap on preload, afterload, and then it's just like hard to connect it to then like systolic and diastolic and like pressure and all of that, so.
Yeah, so preloads are volume, afterloads are basically our blood pressure. Like if you get into your reading, it's way more complex than that, but if we just simplify it, you know, like the little yellow book, Nursing for Dummies, like that's where I'd like for us to be, just basic understanding. Because you guys are gonna grow after you get out of this program, so just very basic understanding. Preload's gonna be your volume, afterload's gonna be your pressure. So anything that we do that affects your volume is going to decrease preload. I want to decrease preload and afterload because I don't want my heart to have to work hard. Because it's either all stretched out and it doesn't pump well, which is the HFR, EF, reduced ejection fraction. Or what's the HFP? That's the diastolic dysfunction. That's when the heart muscle is just big and thick, and so there's no fill time. So I can't, or there's no fill space. Because now the space was this big, now it's this big. So I don't get a lot of good space to fill up with blood. Those patients tend to do well at home, don't have a whole lot of hospital admissions, we can keep them stabilized on their, spiralolactone, home beta blocker, home Entresto. Like, they tend to do pretty good because their ejection fraction is preserved. So they usually have a good one. It's those, systolic dysfunction, those are the ones y'all will see.
So you said the HFE, the diastolic, that's the,
Big, thick heart muscle.
that's more like the right-sided.
Nope, so that's a good question. When we're talking about systolic and diastolic dysfunction, those are two different types of heart failure. It can happen in the left or right or both. And then the reduced ejection fraction, that also can happen left or right or both. So it's just, is your heart big and boggy and won't contract well, or is your muscle thickened? The symptoms are gonna show me if it's left-sided or right-sided. So if it's left-sided, we've said pulmonary dysfunction, that's when people come to the hospital because I can't breathe. Right-sided, what are their symptoms gonna be? Yeah. Rest of the body, they're gonna be very edematous, ascites, tired because they're just lugging around extra water weights. So they may be short of breath, but it's more because they've got a whole bunch of extra weight on them. They may have ascites with the diaphragm pushing up on them. So their shortness of breath has more to do with a weight issue as opposed to actual fluid in their lungs. But then you get the really fun people that have both. Those come to the hospital a lot too.
So do you first kind of figure out if it's diastolic heart failure, and then you take that and figure out if it's left or right sided?
All right, what diagnostic test will tell me that? Echocardiogram. Because the echocardiogram is going to tell me, do I have a thickened muscle, because it's going to tell me the structure, and it also is going to tell me how good the contraction is. It's going to tell me what my ejection fraction is. So echocardiogram is going to be my point to find out what's going on. Because I can get all that, like, have y'all seen an echocardiogram? Like, them folks get in there and they're like, done. Like, it doesn't take long at all. Now, if we gotta do the TEE, that one's a little bit more involved. But I don't need all that just to find out what kind of heart failure I got going on.
Is there an order of diagnostic tests, like you do, like transcutaneous or whatever, and then go into esophagus or?
So why would I wanna do a TEE?
Blood clots.
So the main reason I do a TEE is to look for clots, to see if there's any clots in the heart. Typically don't have to do a TEE, like do that invasive of a procedure just to find out about their heart failure. So those folks come in and get the transcutaneous heart echocardiogram fairly commonly. Anytime they come into the hospital with an exacerbation, they get another one. Because it's just somebody rolling down with their ultrasound machine and checking them out. Some of the docs even have their own little ultrasound machines and kind of can get a basic echo themselves. So I had one doctor that bought one from China. He was like, it's not as good as the real one, but it gets me my information I need to make my decisions to get started before the real one comes in.
So on the transcutaneous, you can't see blood clots?
You can, but you don't get a good picture. So those are the ones we really want the TE, so you can very clearly see if there's a blood clot in there. So plus it's more involved. It's, you gotta sedate the person, you gotta get consent, you gotta do all this kind of stuff. Echo, they just literally walk in. All right, we're done. Other heart failures. All right, so not too bad on heart failure. We'll come back to coronary artery disease and we'll do some review of that. So let's get into our new content. I say new content, but y'all really have already gone over a lot of this stuff, so it should be kind of familiar. Pulmonary embolisms. So pulmonary embolism, speaking of blood clots. This is our clotting issues. We're gonna have two clotting issues. We got pulmonary embolisms and strokes. So we're gonna start off with pulmonary embolism. What's the main reason people get a pulmonary embolism? DVT. So this is the DVT highway. It goes right up from the leg, up, it's gonna bounce around through the inferior vena cava, bounce around in the right atrium, bounce around in the right ventricle. It's not gonna get stuck in the heart because it's a big open chamber. But then it's gonna bounce out to the lungs. Why does it get stopped in the lungs? Why didn't it just go through the lungs and come back to the left ventricle? Because when you get to your lungs, it gets narrower and narrower and narrower because you get all the way down to the alveoli with the capillary beds and it can't get through. So it doesn't have a chance to go through the lungs and come back to the left side of the heart. So it gets stuck and it's gonna cause some problems. So what kind of symptoms is my patient gonna exhibit? Chest pain, shortness of breath. So, no, that one's gonna be for pulmonary edema, not pulmonary embolism. So they may have a cough, but it would be a dry cough. It's more a cough because they're trying to catch their breath and they can't feel like they can't breathe. So not really much of that. What else? That one really is just as if it's fat, related to a fat emboli. Most of the emboli we have are gonna be blood clots, so not typically. That's one of those NCLEX things. Fat emboli likes petechiae.
Halitosis.
All right, so if it's bad, so let's kind of talk about the range of symptoms. So with pulmonary embolism, we can have very minimal symptoms, or we can drop dead instantaneously. Okay, so if we go on this worst case scenario, it's a very specific type of tolerance cyanosis. So we will see patients go from nipple line up, blue. It's very distinct. And it's very scary because if that happens, I'm probably not gonna get you back. That's one of those drop dead instantly type scenarios. We had a lady who, so I've got two stories with those kind of worst case scenarios, and then I've got stories for like the lower end too. So we had a lady who had surgery. She would not get up, refused to wear her SCD hose. How many times y'all seen people just rip them suckers right off and throw them off the side of the bed? Refused to wear them. I can't remember why she wasn't anticoagulated, but we had a reason why we couldn't put her on anticoagulants. She was post-surgery. We usually give them a day or two, and then we start them on the low dose. You know, that's pretty typical. Refused to get up. Would not get up. We documented it like crazy that she refused to get up. She transferred out of our ICU to the floor because I can't remember what surgery she had, but it was one that we had to have her in the ICU. She was up on the floor for a few days, and then we hear a code blue called, and the physical therapist was very shaken up. And we go outside and talk to the physical therapist when it was over with, and she said she got her up for the first time, set her on the side of the bed, stood her up, and she said her whole neck and her face turned blue. She went, gone. Like when they laid her back down in the bed, no pulse, never got a pulse back, and she was gone. It's all because when she stood up, that DVT broke loose, and it lodged right in, you know, the main stem bronchus, and there wasn't anything we could do. It sucks. So that's our worst case scenario. So that cyanosis is very right here in the neck, in the head. They turn blue fast and they're gone. On the flip side of that, you can have almost no symptoms and then have pulmonary emboli. So my neighbor, she started having like just some difficulty breathing, goes to the urgent care. What do? Oh, you have a little, probably a little infection. They didn't do a chest x-ray or anything, just symptoms. She's a little short of breath, not feeling great. So they were like, you probably got a touch of pneumonia, give her some antibiotics. Didn't get any better. Still just having a hard time breathing, struggling. And then about a few days later, she started noticing bruising, like in her elbow, bruising in the back of her legs. And she's like, what is going on? She She goes back to the doctor and she's like, it's just getting worse, she can't breathe. They finally do an x-ray and they're like, something's wrong. They send her for some diagnostic testing, which is that VQ scan, which is our common one that we do. Sent her for a VQ scan. Her lungs were filled with microclots, like little tiny itty bitty microclots that was just causing her a little bit of shortness of breath. Then they did a Doppler. She had DVTs all in her arms and all in her legs. So her whole body just decided to clot up. We'll come back on, because I'm gonna ask like causes of DVT. So actually we'll do it now. So the cause of this lady's DVT that just dropped dead on the physical therapist, her cause was what?
Lack of mobility.
Immobility, post-surgery, didn't want to get up, DVT set in pretty quickly. My neighbor was 48, going through menopause. What do we start when we start going through perimenopause? Estrogen, progesterone, what does that do? Risk for blood clots. She told me after she got diagnosed, it was with the pulmonary embolism, she told me she had just started on hormone therapy for perimenopause about 2 months prior. I was like, that was a critical piece of information to help me, like, help you. And she didn't tell the urgent care doctor that because why would you? I'm just a little short of breath. Starting on hormone therapy doesn't seem to matter when you're going into an urgent care. So she left that little tidbit of information out. So when they realized, hey, she's getting worse, let's send her for some further testing, then they started asking the question, are you a smoker? Have you been, immobile for a while? Like, have you had any recent surgeries? Are you on hormone therapy? Like, what medications are you on at home? And they were like, ding, 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 hormones. There it is. It was a big reason why I put off doing hormones for a long time, because she scarred me.
You take them to low dose aspirin.
So it's just a risk of clotting. It's a risk we take. Combined with smoking, that risk goes even higher. We've got our smoker wrist.
Did you say that when she was going through menopause, they put her on hormone therapy and it was estrogen that caused the clotting?
So just hormone therapy, so she was on estrogen and progesterone. But we know with birth control with our young ladies, it's the same thing. We've got the risk of clotting. Any type of hormone therapy for us comes with a risk of clotting. That's why we always push, don't smoke if you're taking birth control, don't smoke if you're taking hormone therapy, because that's a two together, and we don't want to increase our risk of blood clotting. So it's just a risk that we have to talk to our patients about, because I don't know about y'all, but I can't survive without it. Like, no, negative. Put it off for a while. What else is a risk for DVTs? That it? Those are our big ones. Those are our big ones. We've got other types of pulmonary embolisms. You brought up the fat emboli. How do we get a fat emboli? The long bone fractures, you can get a fat emboli. You can get foreign object emboli. Like, that's why we don't mix medications that are incompatible, because what happens when you mix medications that are incompatible? What do? You ever seen medications mixed that are incompatible? Ooh, I need to do that one day. Find two that are still from the hospital, and they frown upon that. If you have two medications that are incompatible and they mix, they crystallize. So then you can inject crystals and cause a foreign object emboli.
Does AFib cause, I know AFib causes clots, but does it cause DVTs, or is it a radiance in the heart?
All right, so that is a great question. AFib is going to send blood clots through the arterial system, because it's a blood clot in the heart and it gets launched through the aorta. So AFib is going to send off clots in the arterial system. DVTs are in the venous system. So your sign, because this is what we talked about last week, remember? Because we said if AFib launches a clot down to one of your extremities, what are your signs going to be of that? And and you guys instantly started telling me DVT signs. I was like, we need arterial signs, that the artery was blocked. So, that's a very good distinction that we want to make. AFib causes arterial clots, DVT is in the venous system. And so this can cause pulmonary embolisms, because it goes straight up to the lungs. It's very rare for AFib to cause a pulmonary embolism, because it would have to bounce all the way through the body and come all the way back up to the lungs. Not saying it's impossible, but it's just not common, because it'd have to go all the way down, bypass capillaries, and come all back. So not too common. Had something else I was gonna say. Oh, we said foreign object. So medications, if they crystallize, how can you tell if a medication crystallizes? What do you think will happen? You can see it. Yeah, if you see, like if you go to push a medication in tubing and you see it turn white and cloudy, that's, you need to get it out, take that medicine out, throw it away, because it's crystallized. If you mix them up in the syringe, it turns cloudy or white, you see anything other than clear, it's crystallized, get it out. So you can have foreign object, emboli. This is why we always tell you guys, like when you take out an IV, make sure you see that the IV is intact, that it didn't break off and cause a foreign object, emboli. And then we also have one more type of, and two. Pregnant ladies can get what type of emboli? They can get amniotic emboli during childbirth. That's so rare. But then we also can get air emboli. How can you get that? Injecting air. Now, granted, you gotta inject a lot of air to get one. Considering with the echo, they do the bubble test and inject air. I mean, you have to inject a lot to get air emboli. This would be like gross negligence on your part to inject that much air, but it is possible. But for you guys, when you get out there, like we don't do validations on how to take central lines out. So like if you have a central line and you're gonna be removing it, that is the most common way to get an air implant. It's the removal of a central line. So you guys will learn that after you get out there, because it's a check off. Just make sure you follow your procedure. Because this is a very short distance from a hole to the outside world where there's air, straight to your heart. So just be aware that can happen. So there's a very specific procedure you have to follow when removing the central line to be safe. All right, so we've got symptoms that can range anywhere from a little bit of shortness of breath and some annoying things that may kind of mimic like a pneumonia or like a chest cold, something like that, all the way up until like you drop dead instantly. So the symptoms range dramatically. So diagnostic, we've got them up there. Pulmonary angiogram, so this is the same thing as a heart cath, but they just start looking in the lungs area. MRI, that one's not that common unless we're on this range of the symptoms, like the very low symptoms. Like MRIs take 45 minutes. Like if you're real severe, I can't send you for an MRI. It's just too long. VQ scan, this is kind of similar to like a CAT scan, but we use contrast. So if you want to think of a VQ scan, it's a ventilation perfusion scan. I don't know why they went Q. Why didn't they go VP? Ventilation perfusion. But it's basically a lung CT with contrast, using a little bit different techniques from radiology. So they can see the perfusion through the lungs. So VQ scan is kind of the quickest diagnostic test we can do to find out about pulmonary embolism. Or they can do just a basic CT with contrast as well. VQ is just going to be a little bit more specific to the lungs. All right, we confirmed pulmonary embolism. What do we do? What's the treatment? Dissolve the clot, which would be what medication?
Warfarin.
All right, so our thrombolytics. So thrombolytics are our treatment for pulmonary embolism. So we want to try and break up the clots. Are those medicines 100% safe?
Okay.
they are very dangerous. So we had a board with those, and I said we would talk more about it this week. So let's go ahead and start talking more about it. So thrombolytics, they are very dangerous medications. A lot of people can't take them. Who can't have it?
What, recent trauma or surgery?
Recent trauma, especially recent head injury, no nos, because the medicine's too dangerous. It might cause a lethal bleeding if they've had a recent trauma. When I say recent, because I'm going to say that word a lot, recent, what kind of time frame are we talking? So, like 2 weeks. I'm talking like real recent trauma. 2 weeks is going to be an absolute no. Anything longer than that, it's going to be weigh the pros and the cons. Like, we could possibly give it. It may just depend on the level of the injury. But within that 2 week time frame, no. So after 2 weeks, we're going to weigh the benefits versus the risks. How bad was the injury? That kind of stuff. Who else can't have it? So recent trauma. Who else?
This having stroke.
Okay, if they had a hemorrhagic stroke, we're going to talk more about stroke in just a minute. That's our next content. So hemorrhagic stroke, because that's a bleeding stroke. No. What else? All right, if your blood pressure is unsafe, like I say the word uncontrolled, but that's what the literature says is uncontrolled. But let's talk about what that means. That means like your blood pressure is like 180 over 110, like scary high blood pressures. Okay, this is not talking about somebody walking around with a blood pressure of like 165 over 90. That's not that bad. We're talking like 180s systolic, 100, 110s diastolic. So if our blood pressure is just way out of range, no, they can't have it. Too high of a risk, we're going to blow out a vessel and bleed to death in your head. What else?
Patient with atherosclerosis be able to take it?
They can take it. Who else can't have it? So intracranial bleeding, so it's going to cover our head injuries, any kind of hemorrhagic stroke. That kind of covers that. What else do patients come into the hospital all the time with? Maybe if they take NSAIDs every day.
Do you bleed?
GI bleeding. So recent GI bleeding. Again, 2 weeks. Recent GI bleeding. Are we seeing a theme here? Any kind of recent bleeding? Because if I'm giving them a clot buster and they've developed clots in their body to deal with the bleeding issue they've had, what am I going to do to those blood clots? I'm going to bust them up and you're going to start bleeding out from where you bled out 2 weeks ago. So any kind of recent bleeding, GI bleeding, trauma, head bleeding, anything, lumbar punctures, no. So recent procedures, no. They specifically call out lumbar punctures because it's very dangerous. What about a female on their cycle?
That sounds fun.
Say it's going to be a risk benefit, but they're okay. Because that's not an actual, that's just a shedding of the lining. But people always think oh my gosh, they're bleeding. But that's a shedding of the lining. It's not like a blood clot type issue. Yeah. So you kind of get the theme here. Any kind of recent bleeding, recent trauma, anything like that where blood clotting has occurred, we don't want to give this to them because it's going to bust all those clots. They're going to start bleeding out. All right, so those people can't have it. So the first thing that we're going to do, if we find out we've diagnosed with pulmonary embolism, we confirm it, we want to give a thrombolytic, the first thing we've got to do is make sure they're safe to have it. Like if you get an order for a thrombolytic, there's a whole checklist that you have to go through to make sure they're safe to take it, because this drug can kill them. So we got to make sure we're safe first. So we've got them cleared. We're safe to give it. What do we want to do prior to starting it? It's an IV continuous drip for usually 36 hours.
Assess first.
Okay.
Check. Vital first.
Okay. Probably already got a really good assessment got my vitals done. It's gonna be a continuous IV drip for like 36 hours.
Paid baby.
And it does not mix with any other medication. That was on the board. I need at least 2 IV sites because we know from our board that medication does not mix with anything else. So if I've gotta give antibiotics, if I've gotta give pain meds, if I gotta give anything else, I need another IV that I can use. Cause I can't use that IV for a thrombolytic. Or, yeah, if a thrombolytic's running, I can't use that IV. What do I wanna minimize? So I got it started. What do I wanna minimize after it started? Alright, so I gotta make sure they're safe. I'm probably gonna keep them on bed rest. I wanna get them. What else am I gonna minimize? Punctures. Hopefully the other IV I got will get me, let me draw some blood from them, cause I don't wanna be sticking them for blood after I've started this, cause then they're just gonna keep oozing from the site I stuck them from. So hopefully I got an IV that's got a good blood return for me so I can draw some blood on. So I want to minimize sticks. Let's say they've got an IM injection that they take every day, like maybe a B12 shot or something. Do I want to give that? No, so I don't want to do those IM injections. So if there's any kind of medication adjustments we need to make those. It either needs to be IV, PO, sublingual, something like that. All right, let's say their belly starts getting bigger and their blood pressure starts getting lower. What do I do? Ooh, stop it, because what does that sound like? It sounds like some internal hemorrhaging, doesn't it? So any signs that I see of internal hemorrhaging, we're gonna stop that medication. So I'm going to be assessing the whole time they're on this medication. I'm going to be assessing for not only signs of bleeding externally, but I'm going to be looking for signs of bleeding internally. So if my blood pressure goes down and my heart rate goes up, that's a dead giveaway that something internally is going on. And I worry about hemorrhaging. Belly gets bigger, if they start having bloody urine, bloody stools, anything like that. I'm going to be watching for that, like just always. They don't have to have a Foley, but if you want a Foley, you need to put it in before you start this. Yeah, PureWicks are good now, so any type of invasive procedure you want to do with the patient needs to be done before this medicine started. And then we're going to minimize any invasive procedures while it's actually running. These are very dangerous things. All right, let's say this person is not a candidate for a thrombolytic. Like maybe they had a GI bleed, like they came in with a GI bleed, so they're still recovering from it. So, crap, can't have a thrombolytic. What's next? You're so quiet. What can I give this person? Do I just say, oh well, sucks for you? Yeah, anticoagulants. So we just start them on a heparin drip. Heparin drip or high dose enoxaparin. So we're going to do heparin drips. They usually stay on a heparin drip for several days, or high dose enoxaparin. So not that little 40 milligrams that you give to everybody post surgery, and just because they're in the hospital. I think everyone gets that little 40 milligrams of Lovenox while they're in the hospital. So we're going to give higher doses. It's usually 1 milligram per kilogram. So big dose of enoxaparin. I know I don't move from the slide very much. I get it. Alright, so I don't know about it. Watch it. They can go in during that pulmonary angiogram and try to do a removal of the blood clot. So that's something that we can do. We can send them down for that. So there's not really a whole lot role of the nurse in that. It's just get them to the cath lab so that they can try and do a embolectomy and pull the clot out. So we had a code at Grandview about a month ago, and it was a patient with pulmonary embolism, and they were, first it was a treat team, so like the Raptors Lions, and they said it's a 25-year-old with pulmonary embolism. And they're like, we're trying to get him to the cath lab, because we had like 4 empty beds, so we knew it was coming to us on clinical. They said, we're trying to get him to the cath lab to do embolectomy, because it's really bad. And then like maybe 20 minutes later, code blue, so he didn't survive. If you go for, like, pretty much we know this pulmonary embolism, they call it code blue, or not gonna have good results. So, but they were trying to get him to the cath lab in order to pull that blood clot out. It's just, if it's real severe, a lot of times we just don't make it, just because the symptoms are so bad. We don't have time. But if we're more on the lower end symptoms, we got time, and that's a possibility that they can do that. Especially if they're not a candidate for a thrombolytic, we can try and get them to get an embolectomy. Or just have a drip. All right, questions, thoughts? So if they have a pulmonary embolism and they're not a candidate for a thrombolytic, we will do a anticoagulant just so it doesn't get worse. Try and keep them stable. Everything you learned in 113 about preventing DVTs is free game for this test. Because preventing DVT should be important to all nurses. So that knowledge is very critical to have. So anything you learned about DVT prevention. So tell me some DVT prevention. Move, did I hear that? Move. What else? SCDs, what else? Alright, elevate legs, but don't do what? No pillows up under the knees. No crossing the legs at the knees. No blocking blood flow at the knees. What else? What about if you're taking a trip? Alright, you do compression socks, and what do you need to do if you're taking a long car trip? Take frequent breaks, get out and walk around. Had a lady dropped in the hallway because they drove 4 hours with no brakes. And she came off her anticoagulant to have surgery. Didn't even make it to the registration desk. So long car trips, make sure you're being safe. Take breaks, compression nose.
When you have a long trip, if you take like aspirin, it's gonna be helpful.
It can help, so like that lady, this was a long, long time ago. So that lady took Coumadin stayed in her system for a long time. They could have transitioned her, like nowadays, they would have transitioned her to a short-acting anticoagulant, so she could have taken it like up until 24 hours before surgery. But that just wasn't a thing back then, like it is now. So if somebody's on a long-term anticoagulant, we have short-term anticoagulants you can take even 24 hours after surgery. So Lebanon gets out of your system really quick. All right, so all that DVT prevention, bring that knowledge with you. All right, let's take a break, and then we're going to get to strokes. All right, y'all ready to talk about strokes? Woo! All right, sorry, I'm a neuro nurse. Y'all are going to get all my neuro next week. Maybe the week after. I'll see when I want to start my neuro stuff. So, starting on strokes. So strokes are an umbrella term. CVA, cerebrovascular accident. When a patient has a stroke, they have either an ischemic stroke or a hemorrhagic stroke. And when a patient presents to the ER, you cannot tell which one they are having. The symptoms are exactly the same. So that's why we say the term stroke, and we give it an umbrella term. Then when they come into the hospital, we're going to figure out through some diagnostics which one they're having. So do I have a clot in my brain to where it's ischemic, so clot here, all the distal tissue dies? Or do I have a hemorrhagic where a vessel has ruptured? Vessel can rupture due to many different things. What do you guys think of when you think of like a head bleed in your head? Aneurysm, I heard that. Trauma, I heard that. What else? pressure. Yeah, that massive hypertension, you can just blow out a vessel in your brain. This is why we don't give thrombolytics to people with out of control blood pressure. So if your blood pressure is super, super high and we give you a thrombolytic, I can bust, one of those vessels can bust and then you're dead because I can't clot and stop that. So hemorrhagic stroke is going to be more your trauma, your uncontrolled blood pressure, and aneurysms. Aneurysms typically do not have any signs until they rupture. So you don't know you have one. One of my friends sent me a picture of her wrist with an arterial line, and it looked like she was in a helicopter. Excuse me, ma'am, is that your wrist? And she said, yes, she had it was a very mild, she had a hemorrhagic stroke, and they had to fly her up to Vanderbilt because we didn't have a bed here in Birmingham. So hers was of unknown origin, so we're thinking she probably had an undiagnosed aneurysm that she didn't know she had until she started having symptoms of hemorrhagic stroke. So those are some things that can cause that. We are going to cover that more in depth in medical emergencies because this is going to cause increased intracranial pressure, and that's all medical emergencies. So for the perfusion test, we're going to come over to this side. We're going to talk about ischemic strokes because this is our stroke from the blood clot. They're having a good old time out here. I can see people having a good old time. All right, ischemic stroke. What's the number one way you can get an ischemic stroke? Get a blood clot up in your brain. Number one cause, AFib. Because that blood clot can launch right out of the left atrium, go to the aorta, and then get one of those three vessels that go right up to the brain. So AFib is the most common cause of an ischemic stroke. Now you can have it for many other reasons as well, but that's the number one cause. Just having all of your risk factors for a heart attack, same risk factors for a stroke. My dad had a stroke, he's got diabetes, hypertension, overweight, eats like garbage. I don't think chips and french fries should be its own food group, but he begs to differ. So any of the same risk factors for a heart attack, same risk factors for a stroke. But number one, AFib. This is why AFib patients need to take what every day? Anticoagulant. Very good. So with a stroke, we can't tell the difference with our signs and symptoms. The only way we can tell is doing some diagnostic testing. So what kind of test am I going to send this person to find out if they've had an ischemic or a hemorrhagic stroke?
CT scan
Send them to a CT. Let's say that's my next question, with or without contrast?
Without.
Without. Why? I believe Ethan, he's got the right answer, but I want y'all to tell me why that's the right answer.
Heck, I don't know. I just ain't know.
That is very true, but I always want us to understand the why of what we do and why we don't do something. So why would I not want to give this person contrast? I don't know which side of the table I'm on right now.
You don't want all that contrast getting in the brain if it's hemorrhagic.
Exactly. If it's this, I don't want contrast getting all up on my brain tissue. It's going to make everything worse. So until I know, no contrast. So if I give them contrast, it's just going to leak out of that bleeding spot. So CT, no contrast. For a little while in healthcare, they tried to change the name to brain attack to make it sound more like heart attack. And I'm like, I think the population understands what a stroke is. I don't think we need to change the term. So I left that up there because I thought it was funny. So a stroke, I think everybody knows what a stroke is. So we're gonna go strictly ischemic strokes. When you're doing your reading, just kind of skip over hemorrhagic for right now. Pick up next content area. So go over the ischemic stroke. So we talked about our causes. So let's talk about our signs and symptoms. I love this little wonky lady right here from Nursing Made Easy books. So let's kind of go through the symptoms. You guys kind of know this. Like when we have somebody with a stroke, what symptoms is like the classic sign?
Face.
Yeah.
Face droop.
We've got kind of one side of the body don't work. So face drooping, lack of movement in one side, arm or leg. So we're gonna have unilateral lack of mobility, potentially. Remember, you have motor and sensory aspects to your brain. So are you always gonna have motor signs? Not always. You could have sensory signs. So in the case of my dad, he did not have any motor signs. He only had sensory signs. One side of his body just got really numb and paresthesias. Like, he called me and he said, my arm feels really numb. I'm like, are you having chest pain? Is it going up into your jaw? And he's like, no, but my side and my leg feel really numb too. You're having a stroke. We need to get you to the ER. And he's like, Mom, we'll go to urgent care. Don't go to urgent care. They don't have a CT machine. I need you to go to an ER where they have a CT machine. What do you do? Go to the urgent care. To which they told him, you're not having a stroke. He said, I'm not having a stroke. I can smile and stick my tongue out straight. Dad, you're having a stroke. I literally teach this content. You're having a stroke. I'm a neuro nurse. You're having a stroke. The urgent care people said, you're not having a stroke, but we need to send you to an ER anyway. Guess what?
The urgent care said he's not having a stroke.
Correct. Not the doctor, but like the people that work there, and those are not nurses for the most part. Like, they hire nurses, but a lot of them in urgent care are not nurses. He goes and gets his CT. He had a stroke, and he spent 3 days at St. Vincent's East on a heparin drip because of his stroke. He's now on medicines for his stroke. That happened like 20 years ago. So we can have sensory aspects or motor aspects or both. So you can have numbness, paresthesias, and lack of movement, one or the other. But he argued with me that he could smile and it would even, so he wasn't sure. So I will give it to like public education. They do know like that's how to check for a stroke, because that is a very common sign, is that you have the one-sided facial drooping. So if you can't smile evenly, you're probably having a stroke. Mental confusion, disorientation, signs of stroke, aphasia. So what does aphasia mean?
Speech problems.
Speech problems. So we've got global aphasia, we've got receptive and expressive. So which one means I don't understand what people are saying to me? Receptive aphasia. What means I can't talk? Expressive aphasia. Expressive aphasia can come out a multitude of ways. It can come out with gibberish. It can come out as I can't actually make any noise at all, like a complete lack of ability to speak. So gibberish, words that don't make sense, saying the right words but not being able to put them in order. So it can show itself in a lot of different ways. Main thing is I can't say what I want to say. Respiratory problems, why? Because it can affect your diaphragm too. You can have a paralyzed diaphragm. So currently my dad, because it's sensory, his diaphragm does move, but he doesn't feel it. So he gets very short of breath with movement because he feels like only one side of his chest is moving. So he's got a lot of numbness. Like his brain is not picking up the reception that his other side of the diaphragm is moving. But his brain don't sense it, so it makes him breathe faster. Brain's really strange. So we can have respiratory problems because if that diaphragm is not moving and it actually is paralyzed, then they can have decreased O2 sat, all those type of respiratory signs. Decreased cough and swallow reflex. So if it's paralyzed one side of the esophagus, one side of the epiglottis, they are a huge what risk?
Aspiration.
Huge aspiration risk. Who clears them to see if they can swallow safely? Speech therapy. So speech therapy is going to be one of our helpers with a stroke patient to make sure they are safe to swallow, because our stroke patients are a huge aspiration. Incontinent seizures. So seizures are a very unreliable sign. Seizures can happen for so so many different reasons. It's just part of the process. Even when we talk about increased intracranial pressure, seizures can happen or they can't happen. There's just so many reasons you can have a seizure. It's a very unreliable symptom, but it does let me know, hey, something's wrong. We need to figure this out. Let's see, we talked about increases, visual changes, we talked about that with sensory as well. So we only see one half of the visual field, so that was the red glasses that we walked around with. So we saw those. Vomiting, hypertension, yeah, so we kind of talked about all those things. So the symptoms that present can also mimic a very easily, very quickly remedied thing. So what do we want to check on anybody that might look like they're having a stroke? Because these symptoms mimic another issue. Bell's palsy just gets to the face, though. But yeah, Bell's palsy looks like a stroke on the face. So all these signs can kind of look like hypoglycemia. So whenever we see somebody having these type of symptoms, we want to check the blood sugar. So we're gonna hope it's hypoglycemia, because can I fix that real quick? I sure can. So that would make me very happy if it was hypoglycemia. So we want to check blood sugar if we see this. So let me go over TIA right here down at the bottom. So do we know what TIA stands for?
Transient.
Transient ischemic attack. So transient, what does that word mean?
Comes and goes.
Like short-term, temporary, comes and goes, like you can kind of use a whole bunch of different definitions here. So transient ischemic attack, so this is gonna be like some, like lay people may term it like a mini stroke or like a pre-stroke. So you'll see signs of a stroke, but then it gets better on its own. So you see different things like syncope, temporary vision changes, temporary hemiparesis, headache, confusions, like some kind of nondescript kind of symptoms. So a TIA, you're gonna see symptoms of a stroke, but it's gonna get better. So this is a very common like treat team call. So I would get called for a treat team, patient showing signs of a stroke, we're headed down to CT to get that CT without contrast. By the time we get down there, the patient's already waking up, moving both sides of their body, and getting better. I'm like, well, we're gonna go get our CT anyways, we're already down here. But those are really warning signs that the big one's gonna happen. So if we have somebody with TIAs, they need a full workup, you know, look at the carotid arteries, check out, you know, what's my heart doing, and see what, you know, what's my blood pressure doing, like what kind of risk factors do we have for a stroke, and start to work on those very aggressively. Because a TIA means we're a big, big risk to have a really bad stroke. So just fun story, my grandmother had TIAs all the time. And so she would wear an apron and my grandpa would wear overalls. And he kept a little walkie-talkie in the overalls and in the apron. And she would have syncope and she would have enough of knowledge and she'd go, I'm going down, Daddy. And he would rush and he said it was like being a 20-year-old. I just catch my breath going. But she unfortunately had TIAs a lot, to the point they came up with that little system. She had full workup, looked at everything, never could find a risk. She never did have a big stroke. It was just something that they had to deal with.
What did you say again? You said that if a patient is having these, that you need to start looking at what again?
What are the risk factors for a stroke, and we need to aggressively find them and treat them. So, like I said, with her, they never did find anything, but she never had a big stroke. Grandmother's like totally, I didn't teach y'all mental health, but like she was a raging alcoholic. Like we had all kind of fun things with Mama, but yeah, she never had a big stroke though. So this is this is a CT scan of somebody on admission showing signs and symptoms of a stroke. So this
got two hemispheres, very easily and clearly defined. I've got the ventricles inside my brain that look very nice and good. So this is a normal CT scan. This patient was showing symptoms of stroke coming in. So, don't see anything, right? This is that exact same patient 48 hours later. This is all dead tissue. So this is all the tissue that died from that ischemic stroke. You can see, I don't really have a ventricle on this side. I'm pushing against the other side of my brain hemisphere. It's even affecting the ventricle on this side. So the point here is that when we do that head CT, you will not see an ischemic stroke immediately, but you will see that there's no bleed. So that's the big thing here. So when you do that head CT, if we see no evidence of a bleed, but my patient's showing symptoms of a stroke, just know 2 days later, this is what their CT is probably gonna look like. It takes time for that tissue to die. It doesn't die instantaneously. It just takes time for it to show up on the CT. But a bleed will show up instantaneously. Like, we will see that. So when we get our report back, no evidence of a bleed, we know we're dealing with an ischemic stroke, and their CT is gonna look worse in 2 days.
Is this a person that got TPA or they weren't given TPA?
This is a non-TPA situation. TPA has really just been a thing like in the last maybe 15-ish years. So it's not been around for a really long time. So it's actually kind of fairly new with treatments. So, and I'm sure I stole this picture a very long time ago. But, because everything was old when I was stealing it then. That's the dates. No. So, let's talk about treatment now. We did our CT. We see no bleed. Patient's having signs of the stroke. What do we give them? All right, that's what we want to give them is a thrombolytic. All right, so now we got to go back through, and we can't just give anybody a thrombolytic, right? All those same things apply. So if they've had a recent surgery, if they've had recent GI bleeding, everything we talked about still applies. Now I'm going to add one more thing for a specific for a stroke. So we already said we're going to go to CT and make sure we don't have a bleed. So hemorrhagic stroke is going to knock me out. Can't have it. With an ischemic stroke, I have a time frame limitation. I cannot give it 3 hours after symptoms present. So when a patient starts showing me signs of a stroke, the countdown starts. You have 3 hours to get them to get a thrombolytic, or you don't give it. So that's why when you do your reading and it'll say, you know, thrombolytics contraindicated in an ischemic stroke 3 hours after symptoms start. So I have a very narrow window to get them to treatment. So, after 3 hours, this tissue, I may not see it on CT, but after 3 hours, this tissue has already died to the point that the vasculature has become very fragile. So if I give them TPA, they're gonna bleed out into this area. I say TPA, thrombolytics, if I give them a thrombolytic. So after 3 hours, that tissue is died enough to where it's too fragile to stand in a thrombolytic. Let's say, and we'll say my dad. My dad woke up with symptoms and called me. Can he have a thrombolytic? Why? I don't know when symptoms started, he was asleep. So when he woke up with symptoms, automatically, I knew he was having a stroke, and I also knew, well, crap. He can't have TPA. Because he woke up with the symptoms. Then he also argued with me for too long. It took him about 6 hours to actually get to an ER. I'm about to come pick you up. This is why he lives with me now. So, argumentative person. All right, so I got 3 hours. All right, let's say, like my dad, he didn't meet that 3 hour time frame. What do? Heparin drip. Yeah, so same thing as a pulmonary embolism. So the treatment for pulmonary embolisms and strokes are very similar. It's just you gotta add that thrombolytic time frame
fallout at this point. So heparin drip or enoxaparin high dose, so we're just gonna do anticoagulant therapies. And then we're gonna deal with whatever else happens. So if my patient has full-sided left paralysis, now what do I gotta add to their care? I like that, everything.
Or
Yeah, PT. If they're full left-sided paralysis, they're now bed-bound patients, pretty much, right? Maybe wheelchair-bound patients. So their whole entire life has to change. You know, we gotta get them up with case management, with social work. Like, how are we gonna, take care of this person? Is there somebody that lives with them? Are we gonna have to go to a skilled nursing facility? We've got all this fallout. So if they're restricted to a bed, now what do I gotta worry about? They're a bed-bound patient. All of those hazards of immobility, pneumonia, DVT, bed sores, UTIs, all of those things. We already said the risk with aspiration. So they may have to have a peg tube now to get their nutrition. So hopefully, so with our thrombolytic therapy, all of these symptoms can reverse as long as I get it within that 3-hour time. All the symptoms can reverse. With a heparin drip or a enoxaparin therapy, they don't reverse as quickly, but if we can get it done and the clot is not too severe, we can see improvement over time with the symptoms, but most likely are gonna stick around for a while. So you'll hear people say, like, I had a stroke, and like healthcare providers say, residual from the stroke is, and whatever symptoms. Or had a stroke, no residual symptoms. So my dad had a stroke, he has residual numbness in his left foot and left side. Doesn't have any numbness in his hand or his arm anymore, but it is on his side and on his left leg. So those are his residual symptoms from the stroke. And then we just, therapies as appropriate, based on whatever they're dealing with. The carotid endarterectomy, this is one of the treatments that we can do to try and prevent a stroke. So, and you guys worked Heart Day in February on Valentine's Day for some of the hospitals? Anybody? Heart Day? No? Cool. So a lot of hospitals will do Heart Day around Valentine's Day, where they do free or insurance covered procedures, like you get a free Doppler of your carotids to just see if you got a lot of plaque buildup, because this is a huge risk of a stroke. They'll do an EKG, a blood pressure screening, and Dopplers on your carotids just to evaluate your risk of a stroke and your risk of heart disease. They'll even do some labs, do your triglycerides, cholesterol, HDLs, all that kind of stuff. So they usually do it in February. Haven't seen it as much post-COVID as we did pre-COVID. Pre-COVID, almost all the hospitals did a Heart Day, because we would go work it as students and help do EKGs and blood draws, stuff like that. So, Doppler the carotid arteries, see what kind of plaque buildup is going on with those carotid arteries, and then they can do endarterectomy and basically roto-rooter all the plaque out of there. So decreases your risk of stroke. So remember what I said, TIAs, let's do a workup and aggressively treat. This is one of those things to try and decrease your risk of a stroke. These usually have to go to step down or ICU for a night, and then they go home the next day. So post-care of a patient who gets a carotid endarterectomy, we're dealing with cutting, because you can see they cut a carotid artery. What's a risk? Bleeding. That's why they have to do step down or ICU for a night. What else? Because we're dealing with the carotid arteries, and we've roto-rooted plaque out of there. So there could dislodge something, so what might happen? Stroke. So there's, just getting this procedure done is a risk of a stroke.
stroke, because a little piece of plaque could break off. What else? What's right here in your carotid arteries that if they get rubbed on too much might happen to your blood pressure?
Baroreceptors.
You have a lot of baroreceptors right here in your carotid arteries. So your blood pressure can go super high or it can go super low because those baroreceptors in your carotid arteries can be like triggered because they've been manipulated. So we usually have protocol orders. They usually come back with an arterial line, so we're monitoring their blood pressure very closely for 24 hours. Their blood pressure can skyrocket, and we usually have protocol orders to something to get their blood pressure down, or their blood pressure can bottom out, and we've got orders for something to get their blood pressure back up. So that way we don't even have to call the doctor. We're just like, oh, blood pressure's looking bad, let's get it down or get it up. So we're worried about those baroreceptors. This is an extremely common surgery. You see this a whole lot, but they're pretty easy to take care of. Usually don't have too many complications, but we just have to know what to watch out for. So we're monitoring for strokes, we're monitoring blood pressures, and monitoring for bleeding.
So you do this to prevent stroke, but a big risk is the stroke.
But really didn't have too many problems with these. The blood pressure issues was the most common, and that's very easily treated with the medicines that we have in protocols. So pretty simple. I had one dude that bled out and had airway occlusion, had to go for emergency drainage of, like, to stop the bleeding. That's really about it. Everybody else did very well. I don't think I ever had anybody actually have a stroke after having this procedure, but we know it's a risk.
Anything else we need to know about prevention, like taking aspirin?
So typically for stroke prevention, there's not a whole lot. Lifestyle modifications and then taking care of AFib. Those are our biggest ones.
We'll just do like one side.
Right, do I?
They just do one side.
For this, yeah, one at a time. Can't do both at the same time, no. One at a time. So I would have people come in, we'd recover them, and then they come in a little while later to get the other side done. I'm like, oh, you're back again. All right, so that's strokes, TIAs, carotid endarterectomies. So the only thing left is sickle cell. And then we can just work on review and practice and apply. So there is a DSIM for sickle cell. I'm not gonna pull it up, but I printed out his orders and his charts. So I'm gonna give y'all some time to read over this, and then we're just gonna go through this chart and break it down and talk about sickle cell. So y'all can read over it, take your little bathroom break as you read over it. I figured it would get there. That you will likely see. So if we look at Tony, he came into the ER with signs and symptoms of a vaso-occlusive crisis. So that is exactly what it sounds like. And what does it sound like? Yeah, you got a whole bunch of blood clots that have now lodged in small areas of your vasculature, and blood can't get through anymore. So is this arterial or venous we are discussing? It can be both, but it can be arterial as well. So main is going to be arterial because that's where the pain comes from. Because why do you hurt?
Gosh.
No blood.
Because you're not getting blood flow and the tissue starts to die and it hurts. So this is arterial occlusive crisis. Sickle cell, the disease, so we didn't talk about it, but you guys kind of know the red blood cells are abnormally shaped. So instead of being rounded, they look like little C's, like little sickles. And because of their abnormal shape, they get stuck together. So it's not like platelet aggregation where they're like clumping up together because they're sticking to each other, it's they get stuck. Because if you've got a cell that's rounded, they just bounce off each other and move on. But if you've got a cell that looks like a C, and then one gets right on top of it, they get stuck on each other. And so they create a blood clot because of their shape, not because of their stickiness to each other. So they get common clots because of the shape of those cells getting clumped up and getting stuck together. So Tony is coming in with a vaso-occlusive crisis, coming in for pain management. He had COVID. So COVID is any type of infection can be a trigger for vaso-occlusive crisis. So in Tony's case, it's going to be COVID, but it could be any infection can trigger a vaso-occlusive crisis. This VSIN was written right after COVID, so they were just like, you know what, we're going to have a VSIN with COVID in it. So they threw that in here. COVID really doesn't have much to play in sickle cell other than it can be a trigger just like any other infection. He was diagnosed with pneumonia, so even worse, started on antibiotic therapy. So he has recurrent vaso-occlusive crises, which is, again, very common. So if you work anywhere that has sickle cell patients, you see the same people over and over and over and over again. So have y'all had clinical where they have sickle cell patients? Yeah? I don't need you right now, so I'm gonna turn you off. And we'll come back. And I'll do the check. Maybe he needs like a cooling break. So recurrent vaso-occlusive crisis, you see these patients, they're frequent flyers. They deal with a lot of pain. So the relationship with patient and nurse may be a little strained because they see each other all the time, and if you're in pain, typically not a pleasant person, and the nurses, I mean, y'all know what I'm getting at here. It's not a good situation, which is why it's amazing that that little boy got cured, that he doesn't have to deal with this in his lifetime. There's been several other patients that have gotten news stories of being cured as well, so it's working for other patients. So he has recurrent vaso-occlusive crisis and acute chest syndrome. So did we look up acute chest syndrome? What is that? Yep, so basically, a whole shower of pulmonary embolisms. So think micro occlusions all throughout the lungs. So showers of pulmonary embolisms. So vaso-occlusive crisis we typically think of in the extremities. Acute chest syndrome, they're all clogged up in the lungs. So vaso-occlusive crisis and acute chest syndrome both are triggered by infection. Acute chest syndrome is a very common cause of death for sickle cell patients. As we talked about how bad pulmonary embolisms can be, right? They can be very severe. So this is a common cause. The statistic that the VSIM gives, which this VSIM is about 4 years old now, the statistics they gave at that time was acute chest syndrome caused 25% of deaths. So big cause of death for our sickle cell folks. Requires hospitalization 3 to 4 times a year. He was here just a month ago, and that is an expected course of treatment, unfortunately. They come in a lot. And he's been on hydroxyurea for 6 months. So we learned about hydroxyurea last week. What is that for? It is a cancer it is a cancer medication. Why don't we give it to sickle cell? Because it helps my bone marrow hopefully produce normal cells, not these abnormal shaped cells. So because of that, what's a big risk of patients being on this medication? So they now have a huge infection risk because I'm decreasing their bone marrow function. And what is the trigger for acute chest syndrome and vaso-occlusive crisis? Infection. So a huge infection risk because they're on an immunosuppressant, and an infection can trigger the vaso-occlusive crisis and and acute chest syndrome. So we're kind of stuck between a rock and a hard place on it. So we give the medication. We need to really, really, really do some good patient education on infection control. Trying to prevent infections because they're at a higher risk. And we know an infection is going to trigger these bad crises to happen. So kind of rock and a hard place, and it just sucks. Thankfully, he's never smoked, so he doesn't. So we're flipping over to his social history, so we don't have that risk of clotting for him. Denies recreational substance abuse, which is awesome because a lot of these folks, they have so much pain that they tend to self-medicate. So we do have a lot of issues with alcoholism and illicit drug use with these folks because they're just in so much pain. These are the people that you can give high doses of pain medication to, and it still doesn't touch them. So they're frequently calling out all the time for more pain medicine, more pain medicine, more pain medicine, which is a lot of between the nurses and the patient, because they just want more pain medicine. We can't give it to them because it's just not safe. So he is alert and oriented. He complains of pain 9 to 10 out of 10, and that's common. They usually, my pain's a 10. In his left arm and left leg. Pain is managed with scheduled oxycodone. What's oxycodone? It is an opioid. So oxycodone we typically give PO. So is that what his schedule? Yeah, so PO every 12 hours, and then he's got a morphine PCA pump. So what does that mean? Patient-controlled analgesia, so he's got the little button. So he's got a long-acting opioid, and he's got an immediate PCA opioid. So he's got a lot of opioids on board here. So what's a risk with him having all this opioids?
Respiratory distress.
Risk for respiratory depression. What else is going to be a problem with him? And addiction. Yes, so we've got to worry about that. We'll talk about something else here in a little bit. He also gets ketorolac IV for breakthrough pain. So what's ketorolac?
Anti-inflammatory.
All right, it's an anti-inflammatory, and we can give IV. So ketorolac is notorious for being damaging to the kidneys. So we're at a high risk of AKI with this medication. So after his medication, he gets down to a 6 or a 7 out of 10. Vitals are monitored. They've got them listed there. Febrile, got some Tylenol for that. So nothing really on his vital signs jumps out. His respiratory rate's 18, so yay, he's not having any depression there. Temp's not too bad, but we know he's on an immunosuppressant, so are we worried about that temp of 99?
Yes.
Because he's on an immunosuppressant, so we know he's not going to have a higher temp like we're used to seeing. So they went ahead and gave him the Tylenol. All right, lungs are diminished in the left lobes with scattered bronchi that clear with a cough. What does this tell me? All right, so he's got the bronchi, which is telling me there's mucus in his lungs. What about these diminished sounds?
Is it the clogs?
All right, so we didn't talk about that with pulmonary embolisms, did we? What changes with your lung sounds with pulmonary embolism? Not much anything, because you can just fine, right? But what's not happening? You go, and the oxygen goes where? So if you've got a blood clot in those capillary beds, the oxygen can't get to the blood. So there's no problem with you going, it's at the capillary bed, the gas exchange is not occurring. So we typically do not have any changes in lung sounds with pulmonary embolisms. So these diminished lung sounds are letting me know his pneumonia has clogged up his lungs and he's not actually getting air all the way down because of mucus. So glad we got that, because we didn't talk about how the lung sounds basically don't change with pulmonary. Let's see, as of this morning, he reported shortness of breath when he got up to use the bathroom, but we encouraged his incentive spirometer. He said it hurt too bad. Why is incentive spirometer a good idea for him? So incentive spirometer does not actually break up mucus. We have another device that breaks up mucus. Do we know what the other device is? I still didn't hear the word I wanted. So chest physiotherapy does, but that's something we would do. But there's actually another little like device, like instead of spirometer, you go. There's another one you go, and it breaks up mucus. You seen it?
Yeah.
So, what?
Is it PFT?
No, there's a pulmonary function test. It's diagnostic. So it's a flutter device, or positive expiratory something. Like I saw it. It's got a new name. It's called Pocket Pep, and I went, did a 12-year-old name this? I can't remember what the last P stood for, but it's a flutter device. So you blow it, and the little ball on the inside spins around and vibrates, creating vibrations all the way down through the lungs, and it breaks up the mucus. So a flutter device would be great for him. But what does the incentive spirometer, what's that going to do for him? Open it up, because he has what are his lung sounds in the lower lobes? Diminished, telling me he is not expanding his lungs all the way down to the bottom. So we need an ICS in order for his lungs to open back up. Because if he doesn't do that, this pneumonia is not going to clear up, and then this vaso-occlusive crisis is not going to get any better. So I've got to work on this infection in order to work on this vaso-occlusive crisis to get better. And this is the vicious cycle, because he doesn't want to do it because it hurts too bad. But if he does it, it'll help him. All right, let's go through his orders. So he's got some kind of standard orders. Oxygen to keep his sats above 92. So, yep, we want to make sure he's got plenty of oxygen. Folic acid. Why is he on? We'll just skip down to his meds. Take that back. We're going to skip down to the fluids. Why is he on sodium normal saline at 120 an hour? All right, yes, dehydration risk, but I'm going to take it further too. That helps with secretions when we have pneumonia. We want to stay good and hydrated, but there's still another reason I want him to have a lot of fluids on board. Yeah, because if I've got cells that are shaped like this and they want to catch up together, I want to make sure they got lots of fluid to float around in so that they don't catch up and get stuck together. So I want him hydrated. So a lot of different reasons for fluids, but I don't even want him to come close to the risk of dehydration. So I want to make sure there's plenty of space for those cells to float around and not catch up to each other. So we're going to make sure he's hydrated. Okay, now why is he on folic acid?
Well, we give him more fluid, so we maybe also need to give him more.
I see where you're trying to go. We'll turn it just a little bit. So folic acid promotes what? Good red blood cell production. So we're just wanting to try and boost them as much as we can to make sure that those red blood cells that get produced are healthy. So that's just a good thing for sickle cell patients to do. We've talked about his oxycodone. We said that was an opioid. That's his long-acting to try and keep his pain under control. We talked about his hydroxyurea, why he's on that, to try and promote good red blood cells, but we know the risk that comes with that. Why is he on Dolcostate? What is that? It's a stool softener. It's not quite a laxative, but it's a stool softener. Why does he need that? Because he is on a lot of opioids. A lot of opioids. So that's where I was going with the risk. He's on a long-acting opioid. He's on the PCA pump with the opioid. High risk of constipation, which brings its own painful issues, and I don't want him to hurt anymore. So stool softeners are very helpful for him being on all of this pain medication. Enoxaparin. It is an anticoagulant, so this dosage is a prophylactic dose, because we talked about, y'all give 40 to everybody. If you gave a Lovenox shot, it was yellow, wasn't it? The little wrapper was yellow, because that's a 40. So everybody gets 40 milligrams as a prophylactic dose. If you get up higher than 40, then we're treating a blood clot. So this is a prophylactic, trying to prevent a DVT, because he's not really getting up and walking a whole lot. He's in a lot of pain, so we don't want him to have a DVT on top of all these sickle cell problems that we're having. Ceftriaxone, what's that? Antibiotics, so we need to treat this pneumonia, try and get that cleared up for him. On Danstrone, what's that for? Nausea. He's on a lot of pain medicine. We know those cause nausea, so we don't want him to get sick. We know what Tylenol's for. We've already talked about the ketorolac. We talked about the morphine. So we just want to try and get him over this, clear up this infection, because the vaso-occlusive crisis is not really going to get better until we clear up this infection.
Okay, how long is an episode?
Because once it's there, like, we're just dealing with the fallout and treating the pain. We know it's triggered, so as long as he's got an infection going on, we're still gonna be dealing with it. There's a lot of patients that say they just live in chronic pain, because there's always, to some degree, some occlusion going on in the small vessels in the extremities. So some patients just live every day with pain. So they're on, a lot of them are on chronic pain medicine, so they're taking meds every day for pain. So going home, so we'll say he gets cleared up, gets sent home. What kind of things does he need to be doing to try and take care of himself to prevent this from happening? Very good infection control, taking care of himself, staying away from sick people, you know, that whole infection control process that we talked about we did. What else? Hydrated, hydrated, hydrated. He does not need to get dehydrated. He needs to stay hydrated. All right, he needs to stay hydrated. What else?
Can we send him some folic acid?
Good folic acid, B12, like those good things to promote healthy red blood cells would be good.
Some hydroxy.
Making sure he stays on his hydroxyurea. That usually comes with having to come in and get lab work done. It can be damaging to the liver, it can be damaging to the kidneys, so we need to come in and get checks on our lab work to make sure that we're being safe. Because if he starts to get too much bone marrow suppression, we may have to hold it for a little bit, because we don't want him to get an infection and trigger this whole process over. Let's start on here. I'm trying to think if there's anything else on there. The only other thing I had put on here was making sure they're up to date on their vaccines. Just again, the infection control, trying to prevent infections. And unfortunately, it's just a vicious cycle, and it's genetic. So unless they can revolutionary cures, this is just kind of the life they have. It's in and out of the hospital, dealing with pain all the time. That's why we have a lot of addiction and a lot of alcoholism in this population of patients.
Are they allowed to get lab-based food? Because of like,
So any type of immunocompromised person are not allowed to buy vaccines, so we prefer not to, but that's gonna be patient and doctor risk versus benefit.
Is every school doctors at home, or is that something just hospital?
So that's gonna be, are we on long-term opioid treatment? Like, are you taking oxycodone every single day for pain management? Yes, you need to be on school software. So it just depends on what their treatment is. If you're on a chronic opioid, you need stool software. Unless you just want to get constipated, I don't know if any of y'all have dealt with that, it's miserable. It's horrid. Sickle cell questions. See what this, I don't know why they name it anemia, because like, it's so different from the
other anemia, but it's got the same name, but it is completely different from the other anemias.
Do we need to know the labs that go with sickle cell?
Mainly just making sure they get their lab work because of the bone marrow suppression and the kidney and the liver damage because of the hydroxyurea. That's the main thing. And then they get like H&Hs,